Good evening, Facebook viewers. Welcome to our TIF Talk Summer Series. My name is Karen Girth, and I am a Market Development Manager at Endogastric Solutions. And I will be your host for the month of July for the TIF Talks. Tonight, we have the pleasure of having Dr. Thomae here to discuss TIF, GERD, and answer all your questions. Thanks for being here tonight, Dr. Thomae.
I'm welcome to be here. I'm very happy to be here.
Thank you for joining us. We also have my colleague and fellow Market Development Manager, Wendy Proffitt, joining us as well. And Wendy will be monitoring our questions tonight. So viewers, please post your questions for Dr. Thomae. He's here to answer them. Dr. Thomae, thank you again for joining us. I'm going to let you guys know a little background on him. He is a board certified general surgeon at National Park Medical Center in Hot Springs, Arkansas. He has over 20 years clinical experience. Dr. Thomae practices a full scope of general surgeries, specializing in minimally invasive and laparoscopic surgical procedures. His experience encompasses trauma, critical care, vein, thyroid, vascular surgeries, and of course, acid reflux and GERD procedures. So thank you again for joining Dr. Thomae. He is not a stranger to our TIF Talks. I believe this is your third time joining us, so we're happy to have you. Third time. So let's kick off our program. We're going to start off tonight with a new short segment called SPF 30 Seconds. Excellent. So we're going to prompt you with the questions. Our first question for you to answer is, what is GERD?
GERD is gastroesophageal reflux disease, which is a long medical name for acid reflux going up the esophagus, causing discomfort and problems.
Right. That within our 30 seconds for SPF 30. Our next question, what are PPIs?
PPIs are proton inhibitors. These are medications that people take. There's all different types, but once it hits the stomach, it causes a chemical reaction on the cells and decreases the amount of acid that's produced from those cells. It doesn't really change the pH, but decreases the amount. Those medications also have a mild effect on the muscle between the esophagus and stomach and help with acid reflux.
Excellent. And my last question is, what happens if I leave my GERD untreated? So if I have GERD, what happens if I don't do anything about it?
So continued acid reflux up the esophagus, as everybody knows out there, can cause some symptoms of heartburn, acid reflux, and it irritates the lining of the esophagus. Over time, in some people, causes Barrett's esophagitis, which there's a low chance of esophageal cancer. But most people, it's just irritates the esophagus and it just gives you symptoms of burning pain.
Excellent. So that's a good kind of segue. Can you explain to the viewers the difference between that occasional acid reflux versus the chronic GERD or reflux that people experience?
So everybody has intermittent acid reflux. They go out for Mexican dinner and maybe that night have a little, and that's not what this procedure, the TIF procedure, is for, and we'll get in that in more detail. But there are some people who just have that muscle, that lower esophageal sphincter muscle between the esophagus and stomach, and it's loose, or they have a hiatal hernia, which is sort of a pouching of the stomach into the chest, and that chronic acid reflux, even during the daytime when they're working, that acid's going up, especially at night when they're laying flat. And that's what's really an issue, and that's what we're here to help people for.
Excellent. So when do you think people should be concerned and seek treatment when they're having these type of chronic symptoms?
Well, how it really works in real life, most people go to the routine pharmacy, Walmart, Walgreens, and they'll buy some over-the-counter PPIs for acid reflux, and that's very reasonable. But when you have to be on those medications for a long time, maybe 6 months, or you're seeing your primary care physician on that medication for more than a year, that's an issue. And the issue is being on those medications for a year starts causing a lot of issues, including heart disease, kidney disease, disease to the brain. The list actually goes much longer than that, bones, but being on chronic PPIs is not a good idea for anybody.
So I know people are on their PPIs, and they are, trying to alleviate their typical heartburn. What are some of the atypical symptoms that people might be experiencing, that they're trying to take the PPIs to alleviate those symptoms?
Well, some of the atypical symptoms are waking up in the middle of the night coughing. So the acid's going up the esophagus, in the lungs, and all at once you wake up coughing, and that's part of that acid reflux. That's probably the number one thing. I would say that's number one.
It's kind of the number. Perfect. And then do you, when you're seeing patients at your clinic, what type of things do you talk to them about treating their GERD, or are there activities that they could do to minimize their symptoms?
Yeah, the routine recommendations is if you put a little block of wood underneath your bed and you have a little slant, that helps. Taking some antacids before you go to bed, that seems to help. That neutralizes the pH. Anything that starts with letter M, Mylanta, Maalox, milk of magnesia, those are all things that can help. Obviously, not eating a good 5 hours before you go to bed, that helps. And everybody has a different. So some people react to Mexican dinners more, and they try to stay away from those foods.
So I guess if the things don't work, such as the wood and taking the Mylanta and all the things that you just described, what are some other options for treating GERD? So they've tried all the PPIs, they've tried all the other types of activities to minimize. What are some other options?
Well, then we start getting into surgical options, and first we start about the gold standard, which is called a Nissen fundoplication. Now this is the big enchilada. This is a big operation where we wrap the stomach, and that basically is preventing acid from going up the esophagus. But it's a big operation with multiple comorbidities. It is a standard that everything is weighed against, but there are really good options, new technologies that are much better than that, and that's why we're here tonight. Before we get into that, another option is something called the LINX, which is a magnetic ring that you can put at the distal part of the esophagus, but it has its issues with erosion and things like that. But the exciting news is, and why we're here, is to talk about TIF, transoral incisionless fundoplication. And that is a minimally invasive, meaning no incisions. We're able to go down the esophagus through the mouth and make a new valve. And by making a new valve between the esophagus and stomach, we're able to prevent the acid from going up. People are off their medications, and it's a wonderful procedure. I've done a number of them, and I'm amazed how well people do with it.
For explaining that. When you do the TIF procedure, I know you have been doing this for a while. Do you do just the TIF procedure, or can you do it and concomitantly, or explain how you do it concomitantly with a hiatal hernia repair?
Right. So when someone comes in from their primary care physician to our office and they have the classic heartburn and acid reflux issues, the first thing we do is place a scope. It's called the EGD, esophagogastroduodenoscopy, and we go down the esophagus and look at what's going on, see if there's damage, see if there's inflammation of the esophagus, which is called esophagitis, and what you led into, to see if they have a hiatal hernia. A hiatal hernia is an outpouching of the stomach up above a diaphragm, and you kind of lose that sphincter tone. If they have a hiatal hernia, then we can fix that hiatal hernia surgically, and at the same time, we can make a new valve with the TIF also to prevent the acid reflux.
Thank you for explaining that. Are there any, or do you have any of your patients come back complaining of any side effects, or how long, is their GERD cured for after they get the TIF procedure?
That's a great question, Karen. So I want to lead into the old-fashioned standard was a Nissen. Now they come back almost, I'm not going to say all the time, but 80% of the time with some type of issue. They can't swallow, they can't burp. Pain is a big operation. With the TIF, the secret is we make this new valve, but it's 270 degrees around instead of 360, not all the way around. So it is basically making your anatomy just like when you were a child, when it was all normal. We're making the exact same valve that you used to have, but you can burp, you can eat, food doesn't get stuck, and we solve the acid reflux problem.
Oh, wonderful. So it looks like we have a ton of questions coming in for you tonight, Dr. Thomae. Wendy, do you have some of those questions for us?
As a matter of fact, I do. So first up is Madeline, who asks, what is silent acid reflux?
Silent acid reflux is when acid goes up the esophagus, and some people have a lining where the pain fibers, they don't have pain with that, but that acid with that low pH is causing damage to the lining of the esophagus and can lead to cancer repeatedly over years. Not everybody, but can lead to that. So that's acid. That would be silent reflux. Reflux that goes up the esophagus, they're not really having the classic acid reflux, but they're coughing at night, they're waking up, the acid goes right into their lungs. That would be silent because they're not really having the classic pain of acid reflux.
And we have a subsequent question about silent reflux, asking about different therapies for that. In addition to TIF, perhaps, do you have experience with strata?
Now, strata, I actually used to own that machine a long time ago, and it's reasonable. It's not as good as TIF, but what we're talking about is using radio frequency to basically zap the bottom part of the esophagus, shrink it, and by doing that, if the esophagus is smaller, there's less acid reflux. It's an option, and it also helps. Nowadays, we use that with people who have Barrett's esophagitis to help with that disease and prevent cancer. But in itself, it seems logical to make a new valve to prevent even acid to go up. But that is one option, and we use it mostly for treating Barrett's esophagitis.
Great, thank you. Now, Carmen is asking, does TIF work for non-erosive reflux, as in reflux that is more gaseous, pepsis?
Well, the TIF is an anatomical correction. So it's not a medication. We are making a new valve, and it will prevent most, not everything, but most liquids from going up. So if the question is, will it prevent food from going up? Well, mostly, not 100%, but mostly. So it prevent other things from going up, but you can still burp. And the true reason we would do a TIF is for acid reflux, not for other things.
Very good, thank you. Rachel is asking, I've had breathing problems, perhaps related to acid reflux, and it has been a year now. Are symptoms such as asthma indicative of acid reflux?
Absolutely, it could be. There are some tests up our sleeve that help determine that. So when we put the scope down and look for the acid reflux, and if we didn't see that, there's what's called Bravo pH testing, where we put a little computer chip right on the distal esophagus. It stays there for a couple days, and we can see the acid reflux, and the patient can correlate it with a little beeper, a little button, and we can see the basically the painless acid reflux into the lungs.
Gotcha. Very good. So I guess that's going to tie into another question from Michael, who asks, how do you know the difference between a GERD cough and an ACE inhibitor cough? I would imagine that that tends to reveal itself in your diagnostic workup as well.
Right. It's a combination of the EGD, seeing if they have a hiatal hernia, doing the Bravo pH testing if needed. However, a horse is a horse and a rose is a rose. If you have a big hiatal hernia and we put that scope down, there's a bunch of inflammation in the distal esophagus, it's most likely acid reflux and not the ACE inhibitor type cough.
Thank you. Last, and then we'll jump back into your conversation, Karen, is Kelly asks, I have been on PPIs for years, 20 plus, and I'm in my early 40s. What other medication options or options do I have? Obviously, we've talked about TIF. Can I take things like Gaviscon or zinc carnosine?
Well, yes, there's other medications that help, and the ones that were just named obviously don't have as much systemic effect as PPIs. Now, PPIs, proton pump inhibitors, are good, but they do have more systemic problems with them if you take them for a long time. So there are, I could list 20 different medications. You have other options, you know, including the antacids and things like that. So all we know for sure is that PPIs work acutely for a little while, but they do have long-term problems.
Very good.
Wonderful.
Thank you. Karen, back to you.
Thank you, Wendy. We have a ton of questions, so I'm excited we're getting through all of them. We've had a lot of questions that I've noticed. Is TIF right for me? I'm suffering from, you know, these specific symptoms. Can you kind of explain, Dr. Thomae, when you see a patient at your clinic, what is the workup for that patient? How do you determine whether they are a good candidate for TIF or not?
Well, just like in medical school, everything starts with taking a good history and then a physical exam and then diagnostic testing. So the history is really important, and who they are, what their weight is, what are they smokers. There's so many things besides just the acid reflux. But as we mentioned earlier, the gold standard of making a diagnosis is the EGD, the scope down the esophagus, and looking for whether they have a hiatal hernia, how much of the acid reflux is affecting the distal esophagus.
So speaking of hiatal hernias, I know that, you know, we talked about how you can do a combination TIF and hiatal hernia repair. What is the recovery like for that combination type procedure versus just a straight TIF?
Great. Let's start with the straight TIF first. So I tell all my patients, if you have a straight TIF, same day surgery, you're going to have a little substernal pain for a couple days, and that's about it. That's about it. Now, when you do the combined, we make small little incisions laparoscopically to fix a hiatal hernia, and on a 0 to 10 scale with pain, with the TIF being maybe a 2 or a 3, I'd say the hiatal hernia repair is about a 4 or 5, and it lasts a little longer. They feel that for a good week. Not that you're screaming in pain or anything like that. A minimal intermittent Tylenol number 3 with codeine for some pain. Every surgeon does their hiatal hernia repair differently. I use a mesh, absorbable mesh. It doesn't erode. I use some staples, some sutures, but everyone does that differently. But in my particular case, they're going to have some mild pain for about a week, and that's about it.
Perfect. Are there any restrictions that they need to adhere by. I'd like to touch on the post-TIF diet. That's always a big concern and question for everybody. But are there any other kind of restrictions they need to adhere to for a little while, just to make sure that they're healing correctly?
Well, generally, we don't want them to do any super heavy lifting, especially if we're doing a hiatal hernia repair. That'd be the number one thing. But people really get back for a regular TIF. They're back to work sometimes in 2 days, or I mean, it's quite remarkable. But heavy lifting would be the biggest issue, and the TIF diet, as you mentioned, that is the big thing post-op. So I tell all my patients, well, I've done this, good many times, and most of the patients are losing about 5 to 10 pounds, and they're all happy about that. And I've never had one complain about the diet. So you start on a liquid diet, and then you go to mushy foods like mashed potatoes and things like that. And we always recommend, least amount of carbs, no carbonated sodas. And so they end up losing 5 to 10 pounds. They're real happy. And obviously, I'm telling you for a fact that the TIF works and people are very happy with it.
That's wonderful. I know we have a lot more questions coming in. So Wendy, do you have any more questions for us?
I do. All right, Dr. Thomae. Allison asks, can TIF be performed if a manometry shows frequently failed peristalsis and a pH study shows moderate to severe acid reflux?
That's a tricky situation, because what you're telling me is that the muscles of the esophagus are not working correctly. And I would tend not to do that procedure on that patient.
Is there an alternative? What if she's looking for solutions there? What would you typically pursue?
Well, I'd like to know whether she has a hiatal hernia, but the description you gave me, there wasn't one. And when the muscle is not working correctly, the peristalsis, the whole idea is the food needs to get into the stomach. And if we tighten up that sphincter too much, they really have a problem, and that you don't want to get into that issue. So sometimes you can cut the muscle at the sphincter and food gets through easily. But it's super rare. I mean, it is somewhat rare, but those particular patients with peristalsis issues, TIF is not for them.
Thank you. Annabelle asks, I've had this, probably GERD, for many years. I have all of the symptoms, but when they do all the necessary tests, nothing shows up. I was also told I have options, but Medicare doesn't cover it. I also have a 2-centimeter hiatal hernia. Any comments there?
That's a tough question. So all the diagnostic studies are negative, and now you're throwing an insurance question into it. But my quick answer is this. We don't always do it, but I would do an upper GI swallow. And a lot of times that reflux can be seen that way, even though the Bravo pH testing is negative, even though the scope putting down looks reasonably negative. And remember, even though we're talking about TIF tonight, there's some people who just need a hiatal hernia repair and not a TIF. And she might be a candidate for that.
Thank you. We have Andrew, who has asked, I'm 33 and have been on PPIs for 13 years. Reflux is moderately managed, but at what point should I consider TIF?
If you're on PPIs for more than 10 years, you need to get off those. And if you can't manage your symptoms on other types of medications, including antacids and things like that, and all the things we talked about earlier about managing GERDs, if you cannot do it with those, you are a candidate for TIF. It's minimally invasive, same-day procedure, takes me 45 minutes to do it, very safe. Why wouldn't you?
Thank you. I have Corey asking, my wife was considering a gastroesophageal valvuloplasty by a doctor in Orlando and it's no longer available. Is TIF an effective alternative?
Possibly, but there's not enough data there for me to answer that.
Thank you. Next is Michael. I have a medium-sized hiatal hernia. From what I understand, I would have to have hernia repair along with the procedure. How extensive is this? I know it will also possibly involve mesh. Have there been a lot of improvements in mesh technology over the past few years?
The improvements of the mesh, there are so many companies out there with mesh, and every surgeon uses different types. And I use a very soft mesh that's absorbable. And it stays there for at least 6 months and then slowly dissolves. By that time, your own tissue grows over the area where you had the hernia. And so you have your own tissue there instead of the mesh. That's how I do it. Some other surgeons may put a permanent one. Once in a while, I may put a permanent mesh in. That it's not an absolute. Some of the bigger hiatal hernias, the real huge ones, we're talking ones that are like this big. Sometimes I use a permanent mesh on those. Obviously, you have to be very careful about erosion in the esophagus. That's what we're trying to prevent. But the size of the hiatal hernia, which is not what was described in this question, is really the key.
Thank you very, very much. All right, Karen, let's take it back to you.
All right, thank you, Wendy. We've got a lot of active questions tonight, so I'm very excited that we've got a lot of viewers on. Dr. Thomae, as we close out tonight, do you have any last words for our viewers or any tips to success in living GERD-free?
What I suggest is everybody's going to have acid reflux, so don't panic about that. So if you're having it once a week, that's just normal, and that's not what TIF is for. TIF is for those patients who every night you're having an issue, or you're on proton pump inhibitors for more than a year. That's what the company would say, but boy, more than a year, you're up to 5 years, 10 years, you're doing damage to other cells in your body. It seems very reasonable to take another option to that problem. And heck, building a new valve at the distal esophagus and making it anatomical like you used to be when you're a child seems very reasonable. It's very safe, and same day procedure, 45 minutes. You come back and see me in 2 weeks. Everybody high fives and is happy. I just did a TIF a couple of weeks ago, and the patient came back and was telling everybody about it. She couldn't believe how fantastic it was, and that's why I'm in the field. It's really great to see patients like that, and it's great to help them.
Excellent. And Dr. Thomae, how can your viewers find you to schedule an appointment?
Well, I'm in Hot Springs, Arkansas, at National Park Medical Center, and the telephone, they might put it up on the screen, but it's area code 501-623-9300. That's our office, and you ask for me, Dr. Thomae, Thomae, and you will see me. You won't see someone else, and we'll help you solve your acid reflux problem.
Thank you. Again, if you're in the Hot Springs, Arkansas area, Dr. Thomae is located at the National Park Medical Center, and his clinic information is up on the screen. If you are located outside the Arkansas area, please visit our physician locator at gerdhelp.com, and you can find a TIF-trained physician in your area. Thank you again for joining. Thank you, Dr. Thomae, for joining us for a third time, and we will see you soon. And Wendy, thank you for joining us, and we'll see you next week on our next TIF Talk. Have a wonderful evening.